Hey Cam followers, it's a Wednesday night. It's a little bit late, I'm afraid. That's my fault, blame me. But please welcome back the lovely James Hunt. Tonight we're going to be talking about non-steroidal use, which is a foundational intervention in managing OA, but it sends a lot of fear into people. So we thought we'd tackle it head on. First of all, I'm just going to show people one of the main pillars of funding for CAM is, believe it or not, this book. We are an independent organisation that aims to try and support you guys with independent evidence-based advice. We do it at the kindness of our own hearts, but things are getting a bit pricey now and we have overheads to cover. And we do that by having our own online shop. And one of the products in our shop, which we're very proud of, is this. It's Why Don't You Listen, an illustrated children's book aimed to try and help families understand about chronic pain expression, how to manage it, identify it. Because sad truth is, we put a lot of dogs to sleep that have maybe bitten a family member, a family friend, and people have lost their confidence in said dog now. We don't want to be there. We want to be avoiding this. And this book is trying to aim to improve the situation. So please do support us. It's £8. It's from the CAM online shop, and I'm sure a CAM ambassador will list it in the thread. Now, more importantly, the amazing, lovely, beautiful Dr. James Hunt is back. And last week we talked about what is possible in a chronic pain consultation, what we can do in referral, in first opinion, and the whole new concept of a mobile service, which is what James is introducing in the southwest. So he's based near Taunton, isn't it?
Yeah, Somerset. Yeah.
Near Taunton. And James is taking all of his worldly knowledge and packaging it up into a car and going to people's houses, which I think is super, because we know that dogs are able to express themselves better in an environment that they recognize, they feel safe and secure in, and we don't have that same ability in the stressful veterinary consult room. So perfect. James, tell them a bit about yourself so that people can have confidence in what you say.
Sure. So I've been a vet for a little bit more than 20 years now, and throughout my whole career I've been very interested in managing pain in animals, from perioperative pain around the time of surgery onto more chronic conditions like arthritis and things like that. So I spent a few years working in practice and then returned to University at Bristol, and I did a master's and PhD there, both looking at different aspects of pain management in dogs and cats. And now I work in a referral centre as an anaesthetist, and I also see pain clinics, as we were saying earlier.
And what's really cool is he lives near me, which I'm really, really happy about. So anyway, I'll stop messing around. I've been at work all day, so I'm feeling very childish this evening. Our chat tonight is about non-steroidal anti-inflammatory drugs. And I often hear lots of negative press about them. And it does break my heart somewhat, because people seem to overlook how incredible they are and how much suffering they prevent. So I thought we'd try and clarify first, what is a non-steroidal, how does it work? And then we'll move on from there.
Yeah. So non-steroidal anti-inflammatory drugs are a class of drug which inhibit an enzyme in the body which is responsible for producing molecules called prostaglandins. And prostaglandins have lots of different effects in the body, but a large part of the family are to do with inflammation. And when a part of the body is damaged, when there's tissue damage, the enzyme produces lots of these prostaglandins, which then are released into the local area, increase the blood flow, increase the attraction of white blood cells. So it's designed to try and help damage the injured area. But as a byproduct of that, they also produce pain and inflammation. So when that goes into a more chronic state, such as we see with arthritis, that persistent inflammatory state leads to the ongoing disability that we see. And so that's why we use these drugs to try and block the enzyme. And reduce the production of these inflammatory molecules.
That's good. I like it. So you alluded to the fact that some of what they block the production of is actually beneficial. So let's talk about why adverse events can happen.
Yeah, exactly. So prostaglandins are a big family of molecules, and they are involved in producing a protective mucus in the stomach lining so that the stomach acid doesn't irritate your stomach. They're involved in maintaining blood flow to your kidney if you happen to be dehydrated or have low blood pressure for some reason. And so because of those activities, if we block the enzyme, we can actually see side effects related to those things. So we can see stomach irritation, and in rare cases, combined with dehydration or something like that, we could potentially see kidney damage.
Yeah, and I think that's something that I hear a lot of, which I kind of get a little bit frustrated, where there's very strong terminology. Oh, you know, that drug caused kidney failure, and this is the sort of thing that I'm hoping by the end of tonight people can go, I'm going to have a bit more of a balanced understanding. It didn't cause kidney failure, but it could have contributed to a problem that was already present. And I think what I hope from tonight, people are just going to be able to have a less black and white, but a more greater understanding of the grey, because there's big supporters of using medications, and there's some really anti-supporters of medication. And actually, at the end of the day, it's the dog in front of us and how they respond to the interventions that we choose. That's really important. So let's just kind of throw out a few. I think we can get away with just saying a few names. So people say, I'm going to do it. So if I can show, there's things like meloxicam, which is Loxicon, Metacam, Inflammacam. They're all different generic trade names of a generic. Then we've got our Firocoxib, which is Previcox. We've got our Robenacoxib, which is Onsior. We've got our Carprofen, which is Rimadyl. There's a big family. Simuljex, which is Simicoxib. There's a lot of them.
Yeah.
Can you explain to people what's happened in the last few years where we've gone from the likes of meloxicam and carprofen into the coxibs?
Yes. So the enzyme story gets slightly more complicated in that there are two different forms of that. And one is more involved in producing the mucus for the stomach and that kind of thing. And the other, which we call COX-2, is more involved in inflammation, but it's not an absolute distinction. You know, there's some crossover between the two. And so one strategy that's been developed to try and reduce tummy upsets primarily has been to develop drugs that are more specific to the second type, the COX-2 enzyme, to try and target the inflammation without also inhibiting the production of protective mucus and things like that. And in dogs and cats, we don't have clear evidence of a reduction in the gastrointestinal side effects to date. So the studies that have been done comparing, you know, an older style drug to a newer one tend to show very similar adverse event rates in terms of the gastrointestinal tract.
Yeah, and that's so in one of the courses we talk about non-steroidal myths, and there is definitely a kind of monologue that circulates saying, oh, well, if you go for a newer non-steroidal, they're going to be much safer. And the real truth, when you look at the literature, that hasn't really been very well demonstrated yet, has it?
Not yet, no. So it's an interesting area, but yeah, I think the difficulty as well is that, as we were just saying before we came live, lots of things cause dogs certainly to vomit, maybe not so much cats, but you know, attributing a cause to a vomiting dog that happens to also be on a non-steroidal can be challenging sometimes.
Yeah, definitely. Well, let's hop straight into this adverse events. We'll quickly run through what sort of things that you might see, the likelihood, the timing of when you might see it, things like hepatotoxicity, etc. Then we'll talk about the adverse event kind of recording system and how it is actually flawed. And the data we get from it can just be guidance, it's not definitive. And then we'll move on from how to potentially minimize those adverse effects. So first of all, what sort of things, if we were, and I am just going to interject here, I did a shout out on a vet forum because I wanted real life everyday data of how often do vets use non-steroidals. And 200 vets, over 200 vets replied within about 48 hours that they all use non-steroidals every single day of their working life.
Yeah.
And when asked, would you, knowing what you know now, stop using non-steroidals? All of them went 100% no.
Yeah.
And the other question was, would you use non-steroidals in your own dog? And 100% yes.
Yeah.
So to give people some context, you know, you hear a lot about adverse events, but the people that are using it day in, day out, in all manner of circumstances, be it ear disease, dental disease, osteoarthritis, surgery, we certainly don't see these adverse events enough in any shape or form to think I'm never going to use them again. Fair to say?
Yeah, that's exactly right. So the side effects that I guess we most commonly associate with this class are tummy upset, so sickness, diarrhea, usually self-limiting, so it might be 24, 48 hours, which then stops. If animals are on a non-steroidal during that time, we would advise, or I would usually advise, stopping it during the period that they're not very well. Potentially if the drug is contributing to it, but also, as we've said, we don't want these animals to become dehydrated. So that increases the risk factor for kidney problems. So I would stop the non-steroidal while they're unwell and potentially losing some body water. There's been some reviews which have looked at the kind of incidence of side effects with duration of treatment and suggested that there's no increase in the risk of side effects with a longer duration, but there is actually better effectiveness of the drug. So when they were given for longer than 28 days, there was better effectiveness of the drug, but no associated increase in side effects. So that gives us confidence that actually they are probably quite useful to use long term. And I suppose the difficulty is predicting which animals are going to develop side effects, because we don't have a useful mechanism to detect that. It really is a case of we see what happens, but the vast majority will not have any side effect at all. And of the ones that do have a side effect, the vast majority, it will be a very minor, an upset tummy maybe for a day or two. And in a lot of cases, we'll take them off the drug and we might reintroduce it after a few days, once they're back to normal, and they then tolerate it fine. So we don't, the association with the drug isn't necessarily so. As we've said, it could be that they had a tummy upset for a different reason.
I think there's so many other variables, aren't there? If we really consider day to day how different our dogs' lives can be, I'm just looking at Luna, what she eats on the floor, they're swimming in the sea, the weather outside. And it is a very difficult conversation to have with an owner that I know you've seen some vomiting. Let's give the gastric mucosa a break. We're going to do 7 to 10 days off. We're going to use this strategy instead to see us through. But because this can be such a dramatic intervention to be used throughout the dog's disease in certainly acute flare periods, I'd like you to reintroduce it. And I'd like us to see if it happens again. And if it happens again, then I am so totally going to be working with you to find an alternative. Because it is hard for people to not want to lay the blame, isn't it?
Yeah. Oh, yeah, exactly. That it's a natural reaction, isn't that you're giving something that may cause an upset tummy. Your animal has an upset tummy, and so you link the two, even though there may not be an actual link. But I suppose what I would say as well is if somebody tells me, oh, they were sick and I saw some blood in it or some dark, coffee ground type material, and I say, okay, let's stop that and we'll have a think about where we go from here.
Yeah.
That's more of a red flag to me.
So what about the other potential side effects? So there's kidney disease. So Caroline Shippies, she's concerned because she's had 3 dogs on long-term Metacam who've had kidney failure at the end of their life. So the key ones people talk about are kidneys, liver, clotting is really where most people throw their energy. So what about kidney disease? What do we know?
Well, so there are reports of kidney failure and kidney disease associated with non-steroidals. As we've said previously, that it should really be only the case that they cause problems in dehydrated states or low blood pressure states, including under anaesthesia. And there's actually some data from cats which looked at cats that already had renal problems, kidney problems, and were treated with lower than the licensed doses of Metacam, but they actually survived for longer than cats with kidney disease who weren't treated with Metacam. So that that's a slight not contradiction, but it's not what we may have expected, knowing what we know about these drugs. So certainly monitoring signs of kidney disease are important when we are using these drugs. So we might want to check a urine sample every 3 to 6 months just to make sure things are working okay there. So I suppose kidney disease isn't an absolute contraindication to using it, but it would make us more cautious.
Yeah, and I think when I've been speaking to Gwen, it's very much an individual choice. And there's a staging system, guys, for kidney disease called RCVS staging, stage 1, stage 2, stage 3. And it is quite common if the practitioner feels that non-steroidal intervention is going to improve the quality of life of that animal, be it cat or dog, encourage them to move more, to pee more, to drink more, to eat more, to maintain a good homeostatic state for the kidneys, it actually could be of benefit. So that clear black and white line, you've got kidney problems, you can never have non-steroidals, is actually not so, isn't it?
Yeah, exactly. In terms of liver, that's slightly more difficult in that those problems are often more idiosyncratic. So it's just an individual reaction. That particular animal doesn't react well to that drug. And it can happen with non-steroidals, it can happen with antibiotics, it can happen with anesthetic drugs, it can happen with any extraneous substance can cause a liver problem. But again, monitoring is the way that we look at those. And also, if your animal seems to be lethargic, seems to maybe have some abdominal tenderness, anything like that might suggest a liver problem, we would usually say, okay, well, let's stop drugs and get them checked over. And I think just having a cautious approach, if things change, is useful. You can try and intervene early.
Yeah, and I think a lot of people really like a very quick association, right? So my dog's liver values have gone up, it must be the non-steroidal. And actually you kind of go, there's lots of other things that can do that. And also raised liver values don't necessarily mean end of the road damage, functional impairment. There are many other things that can cause the liver values to go up temporarily. And what would be very wise would say, okay, let's stop the therapy, let's have a break and find something else. And then if we still feel we need that kind of form of analgesic, let's reintroduce it.
Yeah, so that's the thing, is I think we just need to be clear, or try and have an idea of why the liver enzymes might be raised. For example, if we're using these products in older dogs, things like Cushing's disease are relatively common, which will cause an increase in liver enzymes. So, do we just need to reappraise the situation and say, oh, actually, he's been on this drug for a year and now he's starting to develop Cushing's, so let's think about that. So yeah, it can just be useful to have a whole animal appraisal at that point, and just make sure what's causing the change in liver enzymes and what you might do about it.
Yeah, absolutely. And I think trying to be everybody's friend, in the vet world, quite often we don't have one test that answers all of our questions.
No.
And when we're trying to do the best for someone's animal, it might be that a urine test leads to a blood test, and that blood test, I'm afraid, leads to another blood test. And this is actually very similar in the NHS. I hear from my parents, oh, I've got to go back for another blood test because that one showed this and they now want to test that. And you're like, that is the same in vet medicine. So if you were, say you've got a 12-year-old Labrador, he's been doing really quite well on an anti-inflammatory for the last 6 months to a year, and you're really pleased with how it's doing, and then you go in for a vet check and they do a routine blood assessment, they go, oh, liver values have come up. Something that happens quite a lot is there's no reference, that there's no blood reference to refer to what was the dog's ones originally. The next thing is, as you say, it could be a completely different condition. And that vet's sitting there going, oh, I'd actually really like to ask them if I could do a liver scan, or if I could do a bile acid, or if I can do something else. And there's a lot of inhibition because you're worried about potentially spending that person's money doing further testing. So what I would like is everybody to understand the process so that these conversations can be had without that inhibition. So an owner can go and go, oh, right, liver values have gone up. I understand it might not be linked to the drug, but it could be. Yeah, I listened to this live. I'm really happy to come off. What can I do instead while we have 3 weeks off? And then let's reassess the bloods. Yeah, is that okay? Great. Oh, they've come back down. Brilliant. Okay, well, he did do really well on that non-steroidal. I haven't found anything else yet that quite matches it. I'm willing to reintroduce it, and we'll do the bloods again. That would be like phenomenal. But it doesn't happen like that very much, does it? Sadly.
No, not all the time. But yeah, I mean, you do see that, like, so many things can cause an increase in liver enzymes. They're a very non-specific sign, and yes, sometimes it can be very difficult to pin down what has caused it, but actually over time they come down and you reintroduce the drug and they stay down.
Yeah, exactly.
It's worth I think if you can.
I think if you can, it would be really worth having that understanding that our bodies are always changing. The vet's trying to collect data to make the best possible choice for your dog. So what about clotting? Because that's another one that people talk about. There's also talks about cartilage damage and blah, blah, blah. But personally, I've not ever had any problems using a non-steroidal in a clotting case.
So, yeah, I guess we would tend to avoid them if we knew there was a pre-existing clotting problem. So an animal that had a bleeding disorder. But they are widely used around the time of surgery and haven't been associated with increased risk of bleeding at the time of surgery. Certainly much older drugs, so certainly aspirin is kind of slightly different anyway, so that inhibits platelets irreversibly. So that does have a more prolonged anti-clotting action, which is why it was sometimes recommended for people with clotting, that were predisposed to blood clots. But the other agents don't have that same irreversible action on platelet function.
Okay, cool. So that's most of the categories. I think because somebody talks about ulcers, up here, blah, 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 blah. Do you remember the paper that came out? What about non-steroidals causing ulcers? Now, there was a paper that came out last summer about video endoscopy capsule going through the guts of dogs. And I think it was 11 that were on non-steroidals and something like 9 that weren't. It was a very small study.
Yeah.
And a number of people grabbed hold of that and ran with it in very one direction. And when you actually look at the study in reality, that's not what it was saying. So the study suggested that the dogs that were on a non-steroidal for longer than 30 days were more likely to have punctate gastroduodenal ulceration.
Yeah.
And they'd seen it on these video endoscope capsule. But what the study didn't do is do a video endoscopy before they went on the non-steroidals, so they could say they definitely didn't before and they definitely do now, and the only thing that has changed is this. I can remember the cohorts of the dogs that didn't have non-steroidal and didn't have ulceration were a different cohort. They're a different age group, different disease state, so many differences between the two groups. You're like, you can't really compare them easily. And the really key point is there were dogs that did have punctate gastric ulceration didn't have any clinical signs. It was of no relevance to their systemic health, but the pain relief they got from the non-steroidal did have a massive impact on their health. Am I missing anything else from that study?
No, I think that's right. And there are, if you look in the kind of emergency and critical care journals, there are rare reports of animals that have been treated with a non-steroidal that have a sudden sort of catastrophic gastric ulcer or duodenal ulcer. But they're so infrequent that they justify writing a case report in a journal, I suppose, is what I would say. Nothing we do is risk-free. But, there are millions of prescriptions for non-steroidal anti-inflammatory drugs in the UK each year. And, it's very, very rare to experience a very, a serious effect.
Yeah. Okay. So now let's talk about how adverse events are reported so people can see it's a flawed system. So the data that we refer to, these percentages of dogs that have this reaction or that reaction, well, realistically, we're just getting a glimpse of the number of dogs that are on these medications. The system of reporting isn't employed by many people. So owners that suspect an adverse event are very unlikely to fill in the form. Vets that get told that there might be an adverse event are very unlikely to fill in the form because there's so many other things that could have actually caused that adverse event. It's quite a difficult system, isn't it?
It is. So it's a passive surveillance system. So it relies on. So it's operated by a government agency called the Veterinary Medicines Directorate, and it relies on people actually submitting reports. So taking the initiative and submitting reports, which says, what drug was involved, what animal was involved, what were the effects that you think were attributed to the drug, what harm was caused to the animal. And they will then collate all the data and go through each case report and assign a likelihood to whether the clinical signs were associated with the drug or not. And, lots of them are maybe. But then in terms of the reports that are submitted, so if it's a serious side effect, so it's, the animal ends up in hospital or even worse, passes away, we're more likely to see a report then associated with a drug, rather than if it's a very mild side effect, such as, a tummy upset, which then gets better on its own in 24 hours. So there's already a bias towards reporting more serious side effects. As you said, it's a very small proportion of vets and owners. So yeah, owners as well can submit reports to the VMD, but life gets in the way. You think, oh, I must do that, and then something happens. So again, it's the serious things that stick in your mind. So again, it's serious things that we're more likely to report. And the
newer the medication. So if it's a new medication, because people are a bit wary of using it, if they see an adverse event, they're more inclined to register it. And I think from your article, James, people that have used injectable, so they're more likely in vet care because it was injected. So therefore, that's more likely to be reported because of these biases, aren't there?
Yeah. So yeah, that's it. I mean, if it happens, on the premises, I suppose you feel more responsible and you're more likely to report it. But also, in our paper, we wondered, because injectables are more commonly used around the time of anaesthesia and surgery and things as well. So it might be that we had a conflation of side effects of a non-steroidal injection with all the other things that were going on at the same time to the surgery and other drugs that we used as well. So that might have artificially increased the reporting for the non-steroidal side effects.
Yeah, definitely.
But no.
So now let's.
Sorry. So I was just going to say that the data that we then base our estimates of the probability of seeing a side effect is very difficult to pin down a figure. If somebody says, how likely is my dog to get an upset tummy? It could be anywhere between, if in some studies it's 30%, in other studies it's less than 1%. So
that's exactly what I found. And it's really, really fascinating, guys, because what I've definitely learned in the last few years, when you have one paper about a supplement or a medication, you've only got one paper with 30 dogs in it, you sit there going, how valuable really is this? Because when you've got another product or supplement or medicine that's got 20 to 30 studies, and they often don't agree. And you sit there going, oh. So you get it. What I'm trying to say is the more you know, the less you know in many cases. A lot of articles and studies that come out have different findings, don't they? That's what the glucosamine, for example.
Yeah.
When glucosamine appeared, there was a study that suggested it was really effective. And as more studies have been done, we've actually concluded, no, it isn't beneficial. Yeah. So, I've noticed that as well. Depending on which paper you read, the adverse event rate is very different.
Yeah. And like we were saying, it depends on what gets reported and, what gets picked up. And, a lot of papers, the adverse event rate is exactly the same as placebo. So there's no added risk in using the product, but that can't quite be correct because we still associate these side effects with the use of these drugs. So it's a grey area.
It is a grey area. So let's give people the advice. I'm quite excited. I'm going to be doing some lives at Andrew Hale soon about decision making, about using instinct. Are you ever allowed to use instinct when treating your pet, or do you have to always be objective? So let's give people the tools to be their own masters. So we're going to talk through ways to use them safely. I think we should talk about conversations that they need to have with their vet. Things that they can do at their vets to make it safe. So what are things to use a non-steroidal safely? List off a few.
So to start with, we want to know if that drug is going to be, the reason we're using it is because we've got an animal in pain. So we want to know if it's effective. So we're going to use it at the licensed dose rate, so the full dose. And then that's going to tell us, okay, this drug works for this patient, or it doesn't, and we need to think of other options. Once we've established that it works for that patient, then I think a reasonable period of time, so like a few months at the full dose, so that we get, as we were saying, that additional benefit of the longer term treatment.
Mm-hmm.
At that point, ideally we're doing lots of other adjunctive treatments as well. So it might be physiotherapy, it might be weight loss, conditioning, all those kinds of things. But we can have a chat with our care team about titrating dose. So there's some work that suggests you can safely titrate the dose of a non-steroidal drug and still have efficacy. But that won't be for every dog or every cat. So some, it's like everything. We'd say very frequently, animals are individuals. They respond in individual ways. So some will be able to manage with a lower dose of a drug. Others will need the full dose. And we won't know until we try reducing.
No. But it is also fair to say, because I know that, me and Gwen have done some lives about this. There isn't actually any data to say titrating to the lowest effective dose is any safer.
No, there isn't. No.
This is just human theory of, if I eat less sugar, I'll get less fat. It's kind of like no one's actually done any studies to show that it's any safer, but we do have evidence that as you lower that dose, you can fall out of a therapeutic range.
Yeah.
But I think also, pushing it on, we can come off non-steroidals. I think people forget this. If you objectively monitor your dog and you see resounding improvement in mood, cognitive capability, functional capability, mobility, and you're like, do you know what? He's doing blimmin' well. He's been doing blimmin' well for a few weeks, a few months now. I think we're in a position where we can come off the non-steroidal.
Yeah.
And so that's a reason for people to become more objective. There's a tendency both in the veterinary sector and in the owner sector to put them on the medication, just stay there every day. And forget to actually look and go, do you know what? He's lost the weight. I've sorted out the rugs. We don't throw the ball anymore. I'm not taxing these joints like I used to. He's having less acute flares. I feel safe that we can actually come off this. I'll maintain everything else. That's probably one of the safest ways to use a non-steroidal, is be objective.
Yeah. Yes, very much. And it can also make you realize that actually the drug was doing more than you gave it credit for, because there's some publications. So Margaret Gruen and Duncan Lascelles did one with cats. So they saw an improvement in a group of cats treated with meloxicam, but also with placebo. And it was only when those drugs were, or all the cats then had placebo, that the cats that had previously had metacam or meloxicam saw a decline, and people detected deterioration, whereas actually there wasn't previously a difference between the placebo and the active treatments, because with all studies there's a big placebo component.
Definitely. So that's a good take. That's a really great take-home message for the CAM followers. If your vet starts you on a non-steroidal, does a sufficient course, and Duncan Lascelles a few weeks ago was saying he's 2 weeks. I know many clinicians that are much more content doing 6 to 8 weeks, whatever your time frame of being on that anti-inflammatory, to look whether it's working. When your vet comes off, they're still doing diagnostics, because as you stop the non-steroidal, you might find a decline and you go, oh, actually it was working. Didn't realize. So work with your vet on that one. Other things that I thought about using non-steroidals more safely: the person that is the poo picker is also the drug administrator, because you get the husband takes the dog out, has the diarrhea, and doesn't tell his wife, and they carry on giving the metacam. You've got multiple people in the household medicating. So make one person medicate, have a chart, tick it. The amount of times I have people come in and go, he kind of got double dosed for 3 days in a row because me and my husband thought we were in charge. So have a strategy, have a pill pot, you know, make sure that you talk as a household, you know, how is he? It's so easy to get your mobile phone out, you're on Facebook, you're doing your emails, you haven't really looked at your dog that morning, you just pop it in the food. Make sure they're eating, make sure they're drinking. All of those other things are really important. Baseline bloods, baseline urine. Weight loss. Oh, yeah. When people have actually got the dog's weight down to 30 kilos and they're still given a 40-kilo dose. Loads of things.
Yeah. So that's another area to think about as well is should we dose on the weight of the animal in front of us or the weight that the animal should be? So that can be something to consider as well.
Yeah. No, that is another consideration. And then I guess another thing to kind of like finally finish with, being that we're 10 minutes over already, is it's not that me and James are sitting here going, oh, we're non-steroidal lovers. It's not that at all. I think it's about trying to have a really good look at all avenues. And I hope CAM followers know that I will be equally infused about physio. I'll be equally infused about hydro. I'll be equally infused about weight loss. These are all amazing interventions. But I did feel personally that there's a tendency to give medication bad press when I know that the dogs that I see, and I saw at least 4 today, by the time the owners are noticing pain, they're in pain, you know, and I want to resolve that to the best of my ability as quickly and safely as possible. And this cohort of drugs offers me that. How I choose to use them longer term with all of my other interventions is to be decided partly by the owner. You know, owners that do engage in weight loss, they do engage in lifestyle change, they do stop the bad habits, are more likely to change the reliance on these medications. So I just wanted to clarify some stuff.
Yeah, no, that's the thing. We've got lots and lots of evidence over, 2 decades that these drugs are effective, and relatively safe. There's so many, like you said, so many vets would be happy to prescribe them to their own pet.
Yeah, definitely. We're going to just do a couple of questions. There was one up here. There was a very brief one. Are sighthounds' blood levels different to other dogs as a baseline? Yes. So we're talking about like hematocrit and stuff.
Yes. So they do tend to have different parameters for their red blood cell numbers and things like that. But they also have a tendency to metabolize drugs quite differently in lots of cases. In terms of non-steroidals, I can't think of any major differences, that require us to adjust doses in those types of dogs.
Okay, cool. Katrina, we are hopefully going to have some Facebook Lives coming up this year talking about using non-steroidal and OA related medications with Cushing's, but this isn't the platform that we would be talking about medication for Cushing's. So this is more OA focused, but we do have a very important person coming to talk about endocrine disease and OA. This one. 2 years and being diagnosed with arthritis of the spine. I'm worried about how long she'll be on medication. Is the advice for younger dogs the same as older? Do you want to go for it?
Very much, although I suppose there's potentially greater scope to address lifestyle things. The younger and the potentially more active the dog, then they can adapt to doing physio things, the training. But yeah, definitely in terms of pain management, we'd be happy using the drugs in younger patients. As we've said, monitoring can be important.
I definitely add about the interventions. Both me and James do things like acupuncture and massage and therapeutic exercise provision. And if the arthritis, the spine, they might be talking about spondylosis. And if spondylosis bridges, then it becomes more stable and therefore potentially less painful. So I would definitely, knowing what I know now, is work with a physio and get them to teach you how to palpate so you can assess pain. So you've got your observations of how are they exercising, what's their energy levels like, what's their mood like. So you can use a validated questionnaire for that. But you can also teach yourself to palpate down your dog's back and look what kind of response they're giving you, because you might find 3-6 months with your adapted lifestyle, with your weight loss, with your other interventions, you're coming away from the anti-inflammatories because it's started to stabilize itself and calm down. So yeah, I've got lots of positivity for you. I think things are going to be okay. Urine sample or blood sample for kidney disease?
Well, I suppose if a urine sample is normal or demonstrates that the kidney has normal concentrating ability, we would tend not to be too concerned about kidney problems. So I think first port of call is a urine sample, and then if there's something that isn't quite right, it doesn't necessarily mean there's a problem, but it's worth investigating further. But it depends very much on the discussions you've had with your vet about which they feel is most appropriate for your animal.
Definitely. And a urine sample will probably be under a tenner, whereas a blood sample is going to be 60 to 100 quid, depending on what they're running and where in the country. My dog is on osteoarthritis, which we all know is gabapentin, isn't it? Paracetamol and Librela, and is still lame. My vet says there's not really stronger, more meds he can be on. Any suggestions? I think for me, I'd want to go and just have a complete rethink, because that's a lot of pain meds.
Yeah, that's covering a lot of bases. And like you say, it might be that there's something else going on there. So yeah, I think probably a checkup with your vets to kind of discuss, and maybe even booking a double appointment with your vets to say that he's still
definitely pain related.
Yeah, I mean there are there's as many pain meds as you want, really. It's just that we don't have, we've got great evidence for non-steroidals, we've got good evidence for things like Librela, and then some evidence for tramadol, and then things start getting a little bit shaky. And very much we know in people that if we give a pain medicine to people, then maybe only a third to a half of them will get any benefit from it. So tricky case.
And I would add that when I started doing CAM years ago, the amazing, lovely Nick Jeffrey caught me at a conference and said, I need you to talk more about peripheral neuropathies, because I have so many dogs brought to me, they're on so many pain medications and they're not in pain. And I was like, so you can actually be lame because of a mechanical lameness, where a range of motion of a joint doesn't work anymore, but it's not necessarily painful. You can have a lameness because of a neuropathy, so the nervous system isn't firing, so it's not pain, it's just inability to perceive where the leg is and move it appropriately. So it might be worth you going, right, let's blank canvas, let's just rethink this, and let's do monitoring, moving, static, transitions, good palpation, get a physio involved, bring it all together. You might actually find that there's something else going on, but that's from afar. Our last question, because we've completely blown it today, is and this is something I really want your opinion on as well, because I've heard so many different opinions about using antacids and H2 antagonists alongside non-steroidals. It's commonplace in humans to use anti-inflammatories with omeprazole concurrently.
Yeah.
What do you think about it?
I think, I guess for me, often switching a drug to a different non-steroidal can be, you can find ones that agree more with dogs, but there are some dogs that seem intolerant of all non-steroidals. In those cases, I'd consider using omeprazole alongside, but I think you do need to be, as we were saying about risk and benefit, we do need to be cognizant of the fact that we're giving something that we know is causing a problem to the dog, and we're trying to cover it up then with another drug. Sometimes things like paracetamol, although it's only licensed in the dog for up to 5 days, sometimes we'll use that outside of the marketing authorization for longer periods of time. And some dogs, that seems to provide effective pain relief and agree with their tummies a bit better. So that might be something to look at. Yeah, it very much individual case dependent, I think, in those.
Yeah. And I think that's so I was chatting with Gwen, and she will do it. If the dog is getting such a benefit from that non-steroidal, and you're like, right, actually, if I take that away, we really are going to destabilize the pain. Let's try it with an antacid, etc. But it is very individual, and the owners need to understand the benefits and the risks. I can remember we interviewed Kenneth Jabot. Oh my God, he's incredible. And he was saying, there's evidence that all you're doing is, as you say, potentially masking it, and the ulcerations that are being more proximal in the gastric tract is going to become more distal. I don't know whether that's true or not, but he had his opinions that are you creating a problem elsewhere was what he was suggesting. And then I know Stuart Carmichael, when I've heard him lecture, he said there's actually no studies whatsoever done in dogs to support use or not use.
Yeah. So again, it's one of those areas where we lack very good evidence. Things like Librela, we would expect not to cause gastrointestinal upsets. So if it were available, then potentially that would be something to try.
Yeah. We keep having loads and loads of questions come in, but I'm afraid, bear in mind that this was supposed to be half an hour. I think I'm going to say, let's stop.
Yeah.
Collaborate and listen. No, stop it, Hannah. Right. We're going to be back next week.
Yeah.
And we're having our final chat next Wednesday about a case. You're going to talk us through a case, so we can follow someone's kind of like journey. What? Yeah.
It's a tricky case.
It's a tricky case.
Yeah.
Great. I'm super excited.
Maybe
so thank you so much for. Thank you so much, guys, for listening. It's really great to see such an awesome attendance. I'll try and answer some of the questions later. It might be in the next few days. Please do tell your friends about CAM. We are growing. It's fantastic. We've got a really big announcement to make in the next few weeks, which I'm very excited about. But I'm keeping it stum at the moment. Stum. And James has got a big announcement because he's now on the road, guys. So if you're anywhere in the southwest, in and around Taunton, this lovely gentleman and all of his expertise is available. So we will put his details in the thread in the description so you can get in touch. Until next week, we'll see you later.
Thank you, Cam.